We always like to check cultures because some patients, they complain about symptoms of urinary tract infections, frequency, urgency, pain in the bladder, burning when they urinate. And these can all be symptoms of another condition as well called interstitial cystitis.
Welcome to MENO with Jacqueline Buckingham, the authority on menopause, perimenopause, and wherever you are on the pause spectrum. I'm Jacqueline Buckingham, founder of MENO, and firm believer that menopause is status, not a sentence. If you're here, something in your body or your life is asking for your attention, and you're not meant to navigate that alone. In our first 2 seasons, we started this conversation, won an Anthem Award, and brought you the leading experts before they were on Oprah. Now we're raising the standard. Each week, I bring you the verified providers, menopause specialists, and authorities you need to understand what's happening in your body and what to do next. From the gold standard in HRT and the little pink pill for sexual desire, to the conversations no one else is having about relationships, identity, and mental health. This is the full picture of your health, because this stage of your life is not just about symptoms. This is about how you live, how you feel, and how to embrace it all, because you have arrived. Pausing or not, start here. This is MENO with Jacqueline Buckingham. My next guest is Dr. Anika Ackerman. She's a board-certified urologist and urological surgeon based in Morristown, New Jersey. She's also the reason I like TikTok. We talk about UTIs, IC, we talk about leakage, which is a major issue with menopause, and the difference between stress incontinence and urge incontinence. And the great news is there are phenomenal options for all of these things. She walks us through them and makes it really, really fun. Here is my conversation with Dr. Anika Ackerman. I'm so happy you're here.
Me too. I'm so glad to be here. This is so exciting.
Oh my God, and we're here in New York, and you are like coming before date night. So I just feel like, thank you for making time. Thank you for I feel like I am kind of crashing your date.
No, not at all. This is an excuse to come into the city. We live in the suburbs, so we don't get to come in too often. We have a babysitter tonight, which is nice. We have a 1-year-old, and we're just going to go out on the town.
Oh my God, by the way, your necklace is so cute.
Oh, thank
Mama.
you. Mother-in-law gave it to me, yes. I love it.
Sweet.
Thank you.
And it's baby Leo, right?
Leo, yes.
I only heard him, but I'd love to see him at some point.
That's right. He was running around when we were chatting. He's 16 months. He's a handful, but we are making it work, our first. So
your first.
It's a learning experience.
So a little bit of a learning curve.
Yeah,
they don't give you the manual.
No,
they don't teach you about that in medical school either.
No, they don't.
Yeah,
there's a lot of things we don't learn in medical school.
Right.
A lot about all the things that this show is about as
well. Yes, I'm so happy that you're here to talk to us about. I think the thing that everybody needs to know more about: UTIs and incontinence. And just all things around the bladder.
Yes.
But absolutely UTIs.
Yes. Urinary tract infections are a big problem for women of all ages, and men, I should say, but definitely a larger problem for women.
Yeah.
It can start very young, from childhood actually, which is funny because I got urinary tract infections as a young person, which
really?
I think is what actually led me into urology. My uncle's a urologist, and I remember he was a resident when I was admitted to Hackensack Hospital with a urinary tract infection.
Wow.
And he took me around to all my tests that I had done at the time. It actually was a kidney infection. And from then on, I said I wanted to be a doctor. And I guess, sort of my issues led me to the path of urology. So young women, old women all suffer from this pathology. So definitely a good topic for people to learn more about.
It is, because they've had a stigma around them, because I think people are under the misconception that you only get them from having sex. And that's not correct.
No, definitely not true that they only come from intercourse, but many women do have infections after sex, which is an annoying problem, obviously. You can line up 10 women in a room and there will be one of them that gets an infection every time she has sex, which leads her to not want to have sex, which leads to painful sex. So something that, I work hard with my patients to combat. But in addition to intercourse, other things that cause urinary tract infections, it's probably somewhat hormonal. Older women who have gone through menopause sometimes start to get infections. And a lot of younger women say that they notice that They have flares of pain or infections around their menstrual cycle. But I do also believe that there is a genetic component because, as I said, you can have a handful of women and some of them will never get infections, and then there'll just be one unlucky person for unknown reasons, which means it's probably related to genetics.
What are our options? We've got a UTI, whether it's from sex, whether it's from menopause, whether it's from being dehydrated, because that's one of them too, right?
Right.
Kind of not drinking enough,
Definitely.
or holding in your pee a little bit.
For sure.
So that's important to know.
People who have recurrent infections usually end up at the urologist's office.
Yeah.
They've gone to their GYN, they've gone to their primary care provider over and over again, and then these doctors usually say, listen, I've given you enough antibiotics, why don't you go to the urologist and see what's going on.
Okay.
For these women, usually it starts with a small workup, maybe a kidney ultrasound to ensure there's no anatomic something going on, like a kidney stone.
Okay.
And then, we always like to check cultures because some patients, they complain about symptoms of urinary tract infections, frequency, urgency, pain in the bladder, burning when they urinate. And these can all be symptoms of another condition as well called interstitial cystitis, which doesn't always involve bacteria. But more on that, I guess, later.
Okay, we'll get there.
Yes.
We'll get there.
So we always check cultures. So often I tell women that come in with recurrent urinary tract infections, listen, I'm going to give you a culture to have on hand.
Yeah.
That way, if it's a night, a weekend, or you just can't make it into the office, you're going to go to the lab, drop off a culture, and then call me, and I can give you an antibiotic in the meantime. So that is sort of how we get over the hurdle of not being able to be seen by a doctor.
Oh, got it.
Yeah, so that we're always checking the culture to ensure there's actually bacteria there, and also to ensure that we're going to give them the correct antibiotic because, you may come up with a bacteria that just is resistant to something that we chose.
And then you have to try another antibiotic.
Correct. And then we'll call them and we'll say, hey, we gave you something that's resistant and we need to give you, or we found a bacteria that's somewhat resistant to the antibiotics we give you, we need to switch it up.
Okay.
So that's step one. And usually at that first visit, it may be an ultrasound, it may be a prescription for a culture.
Yeah.
And then also I recommend one, to drink more fluids. Drinking more water just helps to dilute the urinary tract and, flush bacteria out of the urethra. We're very much a water culture. After a certain generation, but older generations really have more trouble drinking water. But we all carry these big bottles, and
we do.
I do notice that we're getting better at drinking water, which is a good thing.
Yeah, we've made it a priority.
Exactly. Then some over-the-counter things we can do. Cranberry supplement is a good idea. So for a long time, we weren't really sure about cranberry. The data
was like, is it, isn't it, is it real?
Right, and it was 50-50 for a while. There were studies that came out that showed cranberry was good. There were some studies that showed it really didn't make a difference.
Yeah.
So in 2023, there was a Cochrane review where they took 50 studies and they analyzed them, and it actually turns out that cranberry does make a difference for urinary tract infections.
Yay.
Yeah. So all those products that people have been buying over the counter, or chugging cranberry juice when you feel the slight tingle, does help. And the reason it does is because there's a sugar in the cranberry that connects to a sugar on the bacterial cell membrane. And when that attaches, it makes the bacteria sort of slippery so it doesn't stick around in the bladder.
I love that.
Yeah, so it gets flushed out naturally.
Okay, and so is that the same as D-mannose or different?
Similar. It's a different compound, a different sugar structure, but they work very similarly. D-mannose is specific for E. coli urinary tract infections.
Oh,
a lot of people hear E. coli and they're like, okay, foodborne illness, kind of dirty food, dirty lettuce, whatever you've seen in the media. But E. coli is actually the number one bacteria that we find in the urine. And so D-mannose specifically combats E. coli infections, which we see very commonly, which is why we recommend D-mannose often. And we have these nice products now that combine both. For instance, this one that I brought along here, UT Balance. This is made by a company, InnoSubs. This is a really good one because this has D-mannose, cranberry, and probiotic, as well as turmeric, which is anti-inflammatory. So that's a really good one.
Ooh, this is nice.
Yeah. And there's a few products on the market that combine the D-mannose and the cranberry.
Okay, and you like this one.
Mm-hmm. And
this looks good.
Yeah, when you're looking for your cranberry supplements, the one thing you want to look for is proanthocyanidin, or it's abbreviated PAX, and you want 36 milligrams of PAX. So even if you're in the drugstore, you don't want to order something online and you just want to pick up something, that's the number you're looking for, 36 milligrams of the PAX, and that's what this Cochrane review found is sort of the magic number to prevent the UTIs.
Okay, does this say the PAX on it somewhere?
Yeah, it does, I think, on the nutrition label.
On the nutrition, okay, so it's not like it's going to say it like on the front.
Well, I mean, a very smart labeling company may have it like loud and clear, but honestly, a lot of people aren't, are so knowledgeable to know that you need 36 milligrams in it. So I don't know that that doctors are even telling patients. They're probably just like, go pick up a cranberry supplement.
Well, exactly. And then you go to that aisle and then there's like 45 choices. And you're like, which one do I do?
Exactly. So that's a good thing to look for.
35?
36 milligrams.
36 milligrams of
PACs.
PACs.
And for D-mannose, I don't know that there's an exact number. I've heard 500 milligrams of D-mannose is good, but I don't know that there's actually a standardized amount that's been studied, and I know cranberry's been studied.
So is this the kind of thing that we can take preventatively?
That's the kind of thing that I would recommend every day for recurrent urinary tract infection sufferers. Yeah.
Okay, so it's not like it gets ineffective by taking it every day.
No, I would say that it's something for people to use as a preventive, so a daily supplement, just like you would take with your vitamins.
Okay, and where do you get this one?
That one is ordered online. They have a whole supplement line for actually female vitality. They make like a Inno Drive, which is supposed to help with sex drive. They make other supplements for men. They have a lot of good products.
Okay, like InnoSubs.com.
Yeah.
Ooh, okay. I like the little diagram on the back. Okay, fun. So we can take that every day.
Yes.
And then that's
just another one. That also has aloe in it, which is known to be anti-inflammatory, and the calcium.
Okay, and what's the calcium going to do for us?
The calcium is actually nothing for urinary tract infections. I think that's just like sort of a whole kind of supplement.
Like throw it on in there.
Yes,
Why
exactly.
not? And aloe is good.
Aloe is anti-inflammatory. So that's actually very good for interstitial cystitis, which we'll get to again. This intimate rose makes a lot of dilators and wands that help with pelvic floor dysfunction and pelvic pain. So a lot of pelvic floor physical therapists use a lot of intimate rose products. So actually that was sent to me with some dilators and things.
Oh, interesting. Mm-hmm. This looks like a good company.
Yeah, it is. It's a very reliable company for that field, the pelvic floor field. It's the #1 recommended amongst urologists.
And third-party tested?
That's good, yeah.
That's a good thing.
Mm-hmm. And then for postmenopausal, perimenopausal, that are just starting to get those infections, estrogen, vaginal estrogen, which I know you just had like the queen of vaginal estrogen on, Rachel Rubin. Yeah. And it's widely seen all over social media, and it's probably on the news too that like we recommend that most women over a certain age should just be on vaginal estrogen. It probably shouldn't be prescription, and it definitely helps prevent urinary tract infections. It seems a little strange, but
it does.
What it does is it lowers the pH of the vagina.
Okay.
So as we get older and we no longer have those hormones around, the pH of the vagina goes up. And the vagina is supposed to be an acidic environment. That's why it's sort of self-cleaning. It doesn't allow bacterial overgrowth or yeast.
Yeah.
So as that pH starts to creep up, there's more bacteria there. And as we know, females, all the holes are really close together. So bacteria can more easily get from one hole to the other, and that can lead to infections. Also, that estrogen is supposed to make the tissue more sort of fluffy with more rugae or folds in it.
Oh.
And if you can imagine, if you have more bacteria there and less folds, there's more sort of, it's easier for the bacteria to slide. Whereas in the folds, it's harder for the bacteria to get from one area to another because they have to sort of make its way through the folds.
Okay.
So the vaginal estrogen is really important. And when I see these little old ladies with urinary tract infections, and they have a stigma in their head about vaginal estrogen, they think it's for sex, they think it's for pleasure.
Right.
And I just do everything I can to say, no, you need this and you will not get infections anymore. And it's true. They need nothing else but a little bit of vaginal estrogen.
Yeah.
Most of the time their urinary urgency will go away, their pH goes down, and their infections go away. It's very important.
Okay, so how do you administer it? How do you take it?
And I have this conversation like 20 times a day with my patients, because the vaginal estrogen comes with an applicator, and I usually say, throw it out. You don't need to do that. If we're using it for urinary tract infections. If you're using it for painful intercourse, you may want to get it up a little higher, and you may want to use that applicator. It's kind of like a tampon applicator. You're like plunging it in.
Got it.
But for my ladies who just have a little bit of urinary tract infection, or who are just doing it to sort of make things more comfortable on insertion kind of thing, I say blueberry size or pea size amount on your finger, and you're just going to rub it in, and you don't have to go all the way in, just a little bit in. And I say rub it in like you're rubbing in your face cream or makeup. Actually rub it in so it doesn't just like leak out in your underwear and cause a mess. But I have that conversation like 20 times a day with my patients. So that's it. It's super simple.
But you are putting it inside.
You're putting it right in the labia there, right underneath the urethra where the pee comes out.
Okay.
And that's going to have that benefit of lowering that pH and just preventing the bacterial overgrowth.
Okay, but that's prescription.
That is prescription, yes. And
wow, it has so many benefits.
Yeah, with all the prescriptions we're writing, I just saw Rachel Room posted today that there's a shortage of it. So, we will be doing our best to try to get more of that made. But, with more and more people realizing how good it is, that's going to be a problem.
I was thinking it had like a whole apparatus.
It's not absorbed systemically. It's not like I'm giving you a hormone patch or a hormone pill. You're literally just putting in the vaginal area just for a local effect.
Sure.
And, even cancer survivors, even probably active cancer patients, breast cancer, uterine, ovarian, you'd be more cautious, but as I said, you're just having that local effect on the vaginal tissues, and it's not going to increase any of those risks that people worry about with hormones.
Oh, that's such a good preventative.
Yeah.
For so long, it's like the only thing we heard about was cranberry.
Right. And, for women who do have the fear of the hormones and who do have active cancers that our oncologists are actually like, absolutely not. We have a laser, a vaginal laser, that will do the same thing as the estrogen.
Really?
So yes, the Mona Lisa Touch.
Oh yeah, I've heard of that.
Yes.
Okay.
So the Mona Lisa Touch is a CO2 laser. And it basically does the same thing as the vaginal estrogen. It causes microtrauma to the tissue of the vaginal canal, which then sort of tricks your body into repairing and replenishing itself.
Right.
So they've looked at slides before the Mona Lisa and after the Mona Lisa under the microscope, and they see that before the Mona Lisa, there's only a few cell layers thick. The mucosa is very thin and friable, and then after it's nice and thick and fluffy again. So you're getting that same added benefit. So for women who are either don't want to use a cream, or don't want to be bothered, and don't want to use hormones, whatever the case may be, they want to do a one and done or really a 3-part treatment and done, I recommend the laser.
Okay, but still that's 3 and you're done. It's not like you do that every year.
You do 1 treatment a year. Usually we recommend a booster. Some women get by with going longer than a year, but we do recommend a one-time booster. But again, it's not doing something every week at least.
Right. And then when you do that, what actually happens? Is it like a device is inserted?
Yes.
Okay.
So it looks like almost like a joystick with a long cylinder at the end. So that gets inserted all the way into the vaginal canal. And then at the tip is where the laser comes out and fires. So basically you advance it up until the cervix. And then the laser fires at the tip, and you slowly retract the laser back, and so you fire against the whole canal. And then I also do a little bit right around the urethra there to get that added benefit.
Does it hurt?
Really, no. I've never had it done, but I've done
a lot of
hundreds on my patients, and really no pain. It takes 5 minutes, 48 hours of downtime, no tampons, no intercourse, nothing in the vagina.
Oh my God.
Most women are really happy with it. It's like the one, I had a med spa, and it's the one treatment. I feel good about all those treatments, but like you go to get a treatment and you had all these great expectations, and then, it wasn't perfect, or, your skin didn't come out glistening. That Mona Lisa, I feel so comfortable because every woman comes out with a benefit and is so happy. So it's a very reliable treatment.
I love that. It's great to know that that really does help with UTIs.
Right. It does. It prevents urinary tract infections. And the data is not quite there for that yet. All the data coming from Mona Lisa is really out of Europe. But it's got to be on the horizon because there's so much anecdotal evidence that it really does prevent the urinary tract infections. And I'm so confident telling my patients that even though it's an out-of-pocket cost, it's not covered by insurance, it will help and it will be worth it for them.
Okay, how much does it cost, just so we have an idea?
Ballpark, 3 treatments in the New Jersey area is around $2,000.
Okay, so it's an investment.
It is.
It's an investment.
For sure.
But if you think about, recurrent antibiotics and what that could do, right? Because we don't want to be on them all the time.
Yes.
Okay, what about for somebody that has the post-coital UTIs?
Yes.
So that's what you call them, right?
Yes, exactly. Post-coital UTIs, infections after intercourse, infections after sex, very common honeymoon cystitis. You've heard that?
Yes.
The vaginal estrogen is helpful.
Okay.
But what I also often recommend is one low-dose antibiotic after intercourse.
Every time?
Every time.
Wow.
If you're having sex multiple times a day, you're probably only going to take like one a day.
Okay.
But yes, every time. And believe it or not, you're taking 1/2 of a dose.
Okay.
And if you're having a full-blown infection, you're going to get probably 14 pills.
Yeah.
And the dosage that I'm giving is 1/2 a pill. So you'd have to do it 28 times to just equal one course of antibiotics.
Okay.
It's in the American Urologic Association guidelines. Postcoital prophylaxis is what we call prophylaxis, means preventive.
Right.
Postcoital prophylaxis is definitely a recommended treatment option for women with these pesky UTIs. There's some other options too.
Okay.
Some over-the-counter stuff. I brought one with us
what
today.
is this? Because I haven't seen this before, and it looks good.
This is Cheeky Bonsai.
Okay.
And this is something that you will mix in water and drink, and it will help to flush out the bacteria. It has all of those good things in it that we've already sort of discussed.
Oh.
And Eucora is another company that makes a similar product.
I've tried their stuff.
You said that, yes.
Yep, and I thought it was good.
Eucora Flush is a similar drink that you have after intercourse. Again, I've had patients that use both of these, and they find them to be reliable, so I do recommend them to those people who are worried about taking too many antibiotics, whether it be for worried about becoming sort of resistant to them, or yeast infections are a problem for some of my patients, so too many antibiotics are not good for them.
Oh, right, exactly.
But I'll tell you, I think that women get more yeast infections from taking the 7 days than the 1/2 dose pill. Even patients that are prone to UTIs aren't necessarily going to get one after just taking one low dose. It's just not enough to disrupt that microbiome.
So we shouldn't be like, oh my God, I'm so worried.
No, and the other thing you could do is take a probiotic.
Oh, take probiotic.
Yeah,
That's
probiotic.
right, probiotic.
And they make really nice vaginal probiotics. I should have brought one of those with me, but there's a company called Bonafide. You've probably come across them already, too.
I have,
They make a nice hyaluronic suppository that's good for lubrication and a good alternative for estrogen. They also make a probiotic that is specific for the vaginal microbiome. You take it 15 out of 30 days of the month, and it helps to build up that microbiome and prevents overgrowth of yeast and things like bacterial vaginosis.
Okay, so it is a suppository.
It is a pill, actually.
Oh, it's a pill.
It's a pill. It has a really unique capsule design, though. It is like a pill in a pill, so the first part gets broken down in the stomach, and then the rest of it somehow gets to the vaginal epithelium more reliably with this like capsule in capsule technology that they have.
So you take it like every other day?
You take it actually 15 days in a row, and then you don't take it for the rest of the month.
Interesting.
Yeah, Bonafide has some really good products out there. They make one for hot flashes. They make one for libido, for sex drive.
Yeah.
And they make the suppository that's very popular, hyaluronic acid.
Okay.
Which I recommend to patients all the time for similar reasons.
Okay. I was going to say why. What's the point?
Hyaluronic acid is that stuff in skincare that makes you super glowy and pulls in moisture. So it pulls in like 1,000 times more moisture than your skin would alone.
Yeah.
So imagine sticking that into the vagina where you have dryness. So it increases moisture without the hormones.
Oh,
and
all right.
There's actually been pretty good studies recently that show that it helps to prevent painful intercourse, and it helps with some of the sexual complaints that women face.
Interesting. Yeah. Okay. And that's a Bonafide thing.
Another Bonafide product.
Sounds good.
It is good. I have a lot of patients that actually alternate. So vaginal estrogen is usually used 3 times a week. So Monday, Wednesday, Friday.
Yeah.
And then they'll use their hyaluronic acid on Tuesday and Thursday. So they always are sort of doing something.
Got it. And the hyaluronic.
I know it's a hard one. Hyaluronic acid.
Do it again.
Hyaluronic acid.
Hyaluronic.
Yeah, you got it.
There we go.
There you go.
Okay, so for that one, that is the suppository.
It's a suppository. Yes.
Okay.
That's a suppository. Clerby is the other one.
So that means you put it up in there.
Yes.
Right?
Yes.
And like it's a tampon, but it's little.
Yes.
And then it absorbs?
Yes. It kind of melts and then gets absorbed.
Okay. Is it messy?
No. Not that I've heard.
All right.
And it's clear, even if it is. It's like a little clear
fine.
discharge, right?
Okay, there's so many things we can do.
There are. I wanted to just go back and mention a couple of other things about vaginal estrogen.
Yes.
So if you're really hesitant about the cream and you don't want that mess, there's a suppository. And that's called Vagifem or Uvafem. So they make it in a suppository for people who don't want to touch the cream, who don't want to get messy with their fingers.
Right.
That's number 2. And then number 3 is a ring. It's a ring that you insert, and it slowly releases estrogen over 3 months. So older women, like much older women, who really can't sort of manipulate down there, they come once a month to the office, and we take their old ring out and we put the new ring in.
That's pretty great. Then you don't have to think about it.
Exactly. And younger women like it too. They just put it in and forget about it, and then they do it at home themselves.
Oh.
Yeah. So that's a good alternative.
Easy.
And again, just a local therapy for the vagina. It's not like the Nuva ring that's making your hormones unfavorable for a fetus. So, birth control. It's just having a local effect on the vaginal area.
Oh, got it. So how are UTIs different than IC?
Good question.
Interstitial cystitis.
Interstitial cystitis is a bear of a problem for us urologists.
Yeah, I'm sure.
Because we don't really know what causes it. It's kind of in the realm of IBS, irritable bowel syndrome, which is not my field, but GI doctors, I'm sure that's the bane of their existence. They don't really know what causes it, but it causes disturbance of bowel movements throughout the month. Same with interstitial cystitis. It's in the family. And it's flares usually of pain. Patients describe bloating. A general awareness of your bladder. We don't have interstitial cystitis, so I'm not feeling my bladder all the time. I don't, unless it's really full and then you feel it. But they just have sort of a general awareness of their bladder. They sometimes tell me that they feel like they need to unbutton their pants. Burning, frequency, urgency keeps them up at night. They have to use heating pads or whatever other treatments we come up with. But initially, it can be perplexing for women because they're convinced that they have urinary tract infections. So they're going to urgent cares, they're going to emergency rooms, they're going to primary care, and these people are telling them that they're crazy and they don't have urinary tract infections, and then someone finally tells them, go see a urologist. And hopefully the urologist diagnoses them correctly, but it's a inflammatory condition of the bladder that does not involve bacteria, and that's a little bit of a controversial subject because there's a lot on social media and then not necessarily the news. A lot of people write on social media about how it's an embedded infection that you need months and months of antibiotics to clear, but I'm not a believer in that. And I think that'll do more harm than good. So it's a inflammatory condition that ebbs and flows and you have flares, and it can be very incapacitating for some people.
Oh, it sounds terrible.
Yeah, and it's usually a diagnosis, a clinical diagnosis, a diagnosis of exclusion. We've ruled out anything wrong with you.
Got it.
We've sent a culture, we've sent numerous cultures. We've sent something called a PCR culture, which is a new technology, a culture that actually detects bacterial DNA in the urine. And instead of just growing out urine on a petri dish and sort of seeing what shows up, it's actually detecting the DNA, so it's quicker and it's more accurate than the prior cultures. So that's a good tool that we always check to make sure that there isn't some low-lying random infection in there that all the other cultures have somehow missed. And when we've done that, then we say, okay, maybe you do have interstitial cystitis, and here's what we're going to do. So first line of treatment, there's multiple lines. There's first line, second line, third line, fourth line treatment, and there's actually another American Urologic Association guideline to treat these people. First line is behavioral. You're going to cut out anything that is considered a bladder irritant. And we have a list of bladder irritants, in our office. But typically my spiel is caffeine, alcohol, spicy foods, anything acidic, lemons, limes, oranges, tomatoes, vinegar, anything carbonated. And people just look at me like I'm crazy and that it's going to be very difficult, which of course for some people it is. A lot of people look at me and they're like, oh, I have GERD. I already don't eat half those things. So the diet. Yeah, because a lot of GERD patients, people with indigestion and acid reflux, they can't really have a lot of those things anyway. Or, people just don't drink caffeine. Good for them. If you told me not to drink coffee, I'd be in trouble. But it's a rough speech for some people because they realize that they have to cut out all these things to make themselves feel better. So that's step one. And then often we recommend pelvic floor physical therapy because they can help with muscle release and dealing with the pain. A lot of times it's pain with bladder fullness, so they teach them different techniques to either recognize cues when they should go before the pain starts.
Oh, I see.
Kind of thing.
I see.
So that's first, behavioral techniques.
All right.
And that's usually what I send them away with. That and then like an as-needed medication. So Azo over the counter is a good one.
Right.
It just helps to soothe the bladder. It turns your urine orange.
Yes, it does.
Pyridium is the prescription one. And then there's a drug called Urabel that I use a lot.
Okay.
And it's a cocktail of different things. It has methanamine in it and methylene blue. It turns your urine blue, so you pee like a Smurf instead of peeing orange.
Oh my God.
Yes.
Pee like a Smurf.
Yeah. So usually something like as needed, I tell them to take anti-inflammatories for particularly bad days.
All right.
And then a product that a patient introduced me to a few years ago is called Pre-Leaf. So like relief with a P in front of it.
Oh, Pre-Leaf.
Believe it's available on Amazon.
Yeah.
And if they're, a coffee drinker or a wine drinker and
Yeah.
they want to enjoy like a cup of coffee or a glass of wine, they can take Pre-Leaf before, and it helps to cut the acidity in the bladder.
Oh, got it. So like how you take lactate if you were lactose intolerant.
Exactly.
Okay.
Yeah, someone introduced a girl that drank sour beer. I remember her. She introduced me to it, and so now I've been telling all my patients to look this up. And patients do say it definitely helps if they want to enjoy like a
great.
red sauce on their pasta or something like that.
Yeah, okay. All right.
So those are like the front line, what you can do in a pinch and what you should start to do
Yeah.
to make yourself feel better before we get into second line treatments, which are off-label medication.
Right.
There was one FDA-approved drug for interstitial cystitis that got taken off the market.
Oh.
That was called Elmeron. FDA took it off because it was causing retinal issues. But then hydroxyzine is a antihistamine.
Okay.
Amitriptyline is a antidepressant that we use in very low doses for the bladder. Yeah, it's interesting.
Really?
Nothing is on label for this. And then the third one is cimetidine, which is a GI drug. And I'll usually try patients sort of in that order, hydroxyzine, amitriptyline, and cimetidine
Yeah.
to see if it helps as a daily medication
Right.
for those who are having like more bad days than good,
Yeah.
more flares.
Okay. But a lot of the times they think they're having UTIs and then they go to urgent care and they do the test and no bacteria shows up. And so the doctor could say, you're crazy.
Could, but often those patients also go to urgent care.
Yeah.
And when they pee in the cup, in the urgent care, they do a dipstick.
Yeah.
And the dipstick just tells you, are there red blood cells there? Are there white blood cells there? It doesn't really give you much information about bacteria unless there's something called nitrites. When you have interstitial cystitis, it's an inflammatory condition. So
Yeah.
you can see white blood cells and red blood cells, which confuses even more of the urgent care doctors. Because then they think, oh, maybe she does have a urinary tract infection.
Right.
And the culture goes out and takes a couple days. So when the culture comes back negative, then they call them and say, don't take the antibiotics. You may, have to
Right.
see a urologist for IC.
Oh my God.
Yes,
It's a whole thing.
it is. And it's distressing for a lot of people because
Definitely.
for some people, they feel like there's never sort of an end to the road.
Yeah.
But I do tell a lot of my patients, I have older patients or even, middle-aged patients who come in and they think they have a UTI and we check and they don't have anything, and then I tell them maybe you have interstitial cystitis.
Yeah.
And they'll say to me, somebody told me I had that 30 years ago.
There you go.
And I often use those stories with young people or whoever who is being first
Yeah.
diagnosed and tell them it's not forever. Some people
Okay.
it goes away for a long time and and that usually makes them feel a little bit better.
Oh, good.
Yes.
All right. Well, there's hope.
Yeah,
I love having hope and then possibilities.
Right, exactly. And then after those medications, there's third line treatments. We can put a cocktail in the bladder. We mix up a few different ingredients.
Okay.
And we put a catheter in and then put a cocktail in the bladder.
Oh.
They do that 6 weeks in a row, once a week for 6 weeks.
Yeah.
We take the catheter out. The catheter goes in, you put the cocktail in, you take the catheter out,
All right.
and they try to keep it in as long as they can. And it's supposed to help to soothe the bladder. A lot of patients have good success actually with we call those bladder installations.
Interesting.
Yes,
Okay.
and then there's surgeries.
And then surgeries.
Yes.
For IC?
Yes.
Oh,
Yes.
what are we doing for those?
So two options, or they kind of go hand in hand. We usually do a cystoscopy.
Yep.
And we're looking for things within the bladder that may indicate that you have interstitial cystitis.
Okay.
The reason we're not doing cystoscopies on everyone up front is because a lot of people won't have any signs. And then,
I see.
you sort of wake them up and you say, it didn't look like you have interstitial cystitis, but you still have all these symptoms. So we're going to say you have interstitial cystitis.
Okay, and
it's
the
a clinical
cystoscopy
diagnosis.
is kind of like a colonoscopy except for your bladder.
Exactly. And
All right.
much easier. There's no prep. You put a small camera inside the bladder. Usually for women, it's flexible.
Yeah.
A small flexible camera in the bladder. We fill the bladder with fluid
Yep.
so we can see around.
Yep.
And then we examine. And we do this for things like bladder tumors, bladder stones. We
Okay.
look for men with enlarged prostates, and we do it for women as well. And what we're looking for with interstitial cystitis sometimes is lesions within the bladder that look like ulcers.
Oh.
That's really bad, I see.
Okay.
Really bad. And so
Okay.
we don't see that often.
All right.
And then the therapeutic, both diagnostic and therapeutic, I should say, procedure is hydrodistension, where we actually fill the bladder to
Yeah.
capacity, to the max it can go.
Oh.
Like really, really stretch it.
Wow.
Hold it for a few minutes and then release.
Yeah.
And we're looking for something called waterfall bleeding. If the wall of the bladder actually starts bleeding, that's sort of characteristic of interstitial cystitis or petechiae, which are little red dots all over the bladder. We're looking for that as well,
Oh.
and that can indicate interstitial cystitis as well.
Boy. Okay.
So it's diagnostic and therapeutic because some women do
Yeah.
get relief from that stretch,
oh, really?
and for months. I have women that we do hydrodistension and I
Huh.
don't see them for a year. And then they come back and then my bladder hurts again and we start
do
the
it
whole
again.
cycle over. Yeah.
Let's talk about leakage.
Okay.
Incontinence.
Yes.
Would you say is a big part of your
Huge
practice?
Huge. Yes. I just posted a TikTok yesterday about incontinence, and
Oh
they're
my God.
usually very well viewed and lots of engagement. So definitely a big.
Yes. It's a big topic.
Totally.
It's
And
a
there's-
huge topic.
yes.
And like with menopause and perimenopause, it's like one of the main things that I think people are like really scared of it. So I wanted to talk about, okay, what's the difference between stress incontinence and urge incontinence? And then what can we do about them so we're not just living in fear
Yes.
and with pads
Yes.
all the time?
Yes.
Yeah.
Nobody wants to wear a pad.
No.
You go through menopause and you don't get your period anymore, and then you have to go right back to the pads, right?
Oh my God.
Or they even make incontinence tampons now, which I don't routinely
Oh.
recommend, but I know people
I
that
did
do
not
use
know
them. Yeah,
that.
they make a tampon that you can put in that sort of supports the urethra.
Got it.
Stress incontinence is that pesky leakage when you cough, laugh, sneeze, try to jump on a trampoline or jump rope,
Yeah.
and you pee your pants.
Yeah.
And I have women all the time, young or old, a lot of young women too, because when you carry a baby, even just carrying the
Yeah.
baby, not necessarily pushing it through the vaginal canal, you stretch, you put a lot
Oh
of
my
strain
God.
and stretch on those pelvic floor muscles.
Yeah.
And that can lead to damage. And, you know, sometimes that the stretch is so vast that the muscle fibers can't come back together enough to prevent that leakage. And
Okay.
the stress incontinence is when, you know, you're coughing or laughing or sneezing and your abdominal muscles are tensing.
Yeah.
And they're overcoming the pressure of your pelvic floor. And so you leak.
Oh, okay. Okay.
And that's definitely one form. And then
Yeah.
the other form, the urgency incontinence, is that feeling where you get a sudden twinge, I got to go to the bathroom, and you can't make it in time.
Okay.
And it often is associated with urine frequency as well. Women or men
Yeah.
who pee every hour, who wake up 4 times a night to pee.
Yeah.
It all has to do with overactive bladder, which can lead to
Okay.
urgency incontinence.
And so why would we have that?
Urgency incontinence tends to happen to women as we get older, as you mentioned before.
Right.
Hormonal.
Yep.
For men, it's because of the enlarged prostate can lead to an overactive bladder.
Got it.
And for younger people, it can be a nerve issue
Yeah.
or just we don't know why a young person has it.
Right.
But anyone with spinal cord injury, some sort of spinal cord lesion like multiple sclerosis, Parkinson's disease,
Yeah.
accident, brain tumor, sometimes the first thing we see is the bladder becomes overactive
Right.
because the nerves from the brain come down, the signals come down to the nerves from the spinal cord. Any
Yeah.
interruption there is going to cause issues with the bladder. MS is a
interesting.
it's a really interesting one. Sometimes it's either eye symptoms or
Yeah.
bladder symptoms that they diagnose at first.
Oh my gosh.
Mm-hmm.
Very interesting. All right. Let's say this is the case with the stress
Yes.
incontinence. So the first one, the one where you cough or you sneeze and you pee a little.
Mm-hmm.
What are your options? What can we do?
There's actually a lot of them now.
All right.
First thing is Kegels.
Okay.
So I tell all my ladies to do a proper Kegel. You're going to pretend like there's a quarter in your vagina, and you're going to squeeze that quarter and pull it up towards your belly button and hold it for a few seconds and then release. And that's one. And there's like some statistic that if you say
Okay.
Kegel to a woman, she's going to automatically do one. So I'm doing them all
I
day.
did.
Yeah. And I'm talking about Kegels all the time, so I'm always Kegeling. But so you do that 8 to 10 times in a row. And I usually tell patients, do it while you're brushing your teeth, because then you're at least doing it twice a day.
Yeah. All right. That makes
or
sense.
at a traffic light, when you're at a traffic light, do your Kegels, or watching TV at commercials.
Okay, but I like that image of the quarter.
Yes, or pretend like there's a straw in your vagina and suck up through the straw
Okay.
to your belly button.
You're going up.
And really hold it.
Hold
and
it.
then relax.
All right.
And that's good. So Kegel exercise is number one. If someone doesn't know how to do a proper Kegel, or they've done their Kegels and it's just not working, pelvic floor physical therapy is a great option.
Okay.
A lot of people don't know that there are pelvic floor, or there's physical therapists that solely focus on the pelvic floor.
Yeah.
And they're wonderful. And they help with things like incontinence, but also painful intercourse, and even people that can't pee and have retention.
Yeah.
They're just pelvic floor issues in general. They're great. That's number two.
Okay, good.
Number three is something that's a little out of the box, but it's a chair that you can sit on. Kind of looks like this.
Yeah.
You could sit on it with all your clothes. It's called the Emcella chair.
Yes.
In our office, we call it the Kegel throne. And you sit on it, you know, like I said, with all your clothes. You can't have any metal in your body. So if you have like a metal hip, metal knee, not great. But it causes contractions of the pelvic floor like you can't do yourself. So super strong contractions, and 12,000 in a 30-minute session. So definitely helpful for those who want a quicker fix than pelvic floor physical therapy.
Right. I tried it.
Yes.
It was amazing.
Yes.
That was like no Kegel I could ever do myself in a million years.
Yeah, at first it's like a little uncomfortable.
Oh my God.
It also supposed to help your orgasm.
Yeah, exactly.
Yeah.
But something that you brought up was it's not a one and done thing.
No.
It's just like exercise.
Right.
You've got to keep on doing it.
Correct.
So if you were going to say to somebody, okay, you know what, you'd be a good candidate for the Emcella, how many treatments would you recommend? And then what's after that?
I usually recommend 6 treatments.
Yeah.
So once or twice a week, 6 treatments total.
Okay.
And then they can see how it goes, but they're probably going to need to re-up in 3 to 6 months.
Okay.
And it's not cheap either.
No.
About $300 a session.
Yeah.
For that. So depending on where you live, it's a good option for those who want the quick fix and who are willing and have time and money to do something like that.
Okay, perfect.
Yeah.
All right, so we got the Emcella.
Yeah.
We got the fun chair.
Yes, exactly. And then there's another V-Tone, which is a device that you insert. It does the same thing as the Emcella chair, but you actually have to take your clothes off and insert it. It just gets sort of right to the point there.
Okay. And no room for error in terms of like the wear part
exactly.
of it.
If you remember sitting on the chair, you kind of have to like wiggle into the right position and make sure you're not getting your butt and make sure you're not getting like your vagina. You want that area right in the perineum, the place between.
Yeah.
So,
I mean, I was like on it a little bit to the side and I could feel it in my leg.
Right, exactly. And the V-Tone, like you said, just cuts that gray zone out.
All right, so that's something that you would obviously do to a patient.
Yes.
And then how many of those?
6 again.
6.
And another thing that you would probably need more. Like you need a re-up.
All right.
Yep.
All right, so we got that as an option.
Yes.
What else?
I do 2 procedures as well.
Okay.
The first one is Bulkamid. Bulkamid is an injectable. It's really cool. It's kind of like filler for your face.
Okay.
It's not hyaluronic acid, but it is 98% water and 2% polyacrylamide. So it's mostly water. The polyacrylamide, that ingredient, keeps it where we put it. So wherever I inject it, it's not going to just like slide around in the bladder.
All right.
So again, we go back to that cystoscopy.
Yeah.
And the patient can be awake for this one. They don't have to be. We can give sedation, but they can be awake. And you take basically a long needle and you put it through the cystoscope, the camera, and under vision, I make little cushions between the bladder and where the urine comes out, the urethra.
Yeah.
And it acts as a barrier. So when you have those cough, leak, sneeze, whatever, then you don't leak. And it's great for women who still want to have babies.
Yeah.
It's also great for women who, you know, maybe don't want to go under anesthesia and want to do something. So very elderly women, or someone who wants to do something quick. It's also been shown to be 92% effective and last for 7 years.
Oh, that's amazing. Just from the one time?
Just from the one time. And after 7 years, what they showed is that you just need like a re-up, basically another injection.
And that's just that water plus
this 2% polyacrylamide.
And it almost makes like a little dam?
Yeah, it makes like a little cushion, like a little mound. It sort of looks like a flower, like you almost make it all around the opening. And you want to basically occlude the whole opening, so you don't want to be able to see through, because the urine will make its way out because of gravity.
Sure.
There's a slight chance of retention after the procedure, meaning you can't pee.
Yeah.
What we do is so easy. You put a teeny little catheter through there and make a little hole. And then they pee, and that's it.
Oh my God.
Yeah, like you don't have to dissolve anything.
Wow.
If you touch it with a catheter, it's gonna sort of open up a little bit, which is why during the procedure there are some nuanced things that you don't want to like touch it during the procedure, but it's a neat, easy thing to do. It takes 3 minutes.
I was just about to say, how long does it take?
3
'Cause
minutes.
It can't take that long.
No.
What's the recovery like?
Nothing. You can go back to work the same day.
I mean, that sounds great.
Yeah.
And is it insurance covered?
Insurance covered. Every insurance.
gosh.
I know. It's a really nice option.
Okay, that's a good
Yes.
one.
I feel like I'm going to be doing more and more of that.
Yeah.
The next option is the sling, which I love the sling. And
Okay.
they've made slings better too. So we
Good.
used to do mid-urethral slings where we made a few different incisions and
Yeah.
then we tunneled the sling sort of underneath the urethra and up to the skin. And now we do something called a mini sling.
Okay.
And it's, about yay big.
Yep.
And it involves one vaginal incision and then just putting it right underneath the urethra. Same day
Vaginal
surgery.
Incision, a vaginal incision.
Yeah, so you don't see anything outside. There's no
Okay.
scarring.
All right.
15-minute procedure, home the same day, no catheter typically. And, women don't leak. That's a little bit more downtime.
Okay, why would you opt for that?
The sling?
Instead of the Bulkamid?
Maybe a little bit higher leak-free, or maybe a little higher dry rate, like meaning you're not leaking as much with the sling.
Got it.
But it's I think the Bulkamid is gonna really take off because it is a much easier procedure.
Sounds much easier. There's no incisions.
Yes.
I mean,
I guess you will still have people that leak with Bulkamid, right?
Okay.
You'll have
Okay.
some, and then maybe they'll move on to the sling, or
Right.
their friend has a sling and they want the sling. It is easy. It's only 15 minutes, but
Okay.
there is anesthesia involved because we are making an incision.
Yeah.
We call it monitored anesthesia care, like you
right.
would get during a colonoscopy. Like we call it twilight.
okay, twilight.
Yeah.
Yes.
Exactly.
All right, and so a little bit of downtime.
Yes. So we don't want that sling to move on you. No squatting, no heavy lifting,
Yeah.
no long distance running for a few weeks.
Okay.
Yeah.
All right, that's not so bad.
And then no intercourse for a few weeks as well while that vaginal incision
Yeah.
is healing.
Okay.
So not too
Also,
bad.
Those are great options.
Yes.
Great options.
Yes.
We got Emcella, we've got the Bulkamid, we've got the sling, and we have
Exercises.
Kegels.
Yes.
Kegels.
Yes.
All right. That's all for stress.
Yes.
Let's go to urge.
Okay. Urgency incontinence, totally different. It, again, is that feeling that you can't make it to the bathroom in time.
Yeah.
We go back to the bladder irritants first. A lot of times, coffee is the culprit. Someone will come in and you'll say, or Diet Coke or something.
Yeah.
They come in and you say, I'm peeing all the time. Doc, help me.
Yeah.
And we go through, what they're drinking, and it's like 10 cups of coffee a day. So that's the first thing to cut out.
Yeah, I would
Coffee
think so.
especially, because coffee is both acidic and caffeine, so it's a double whammy. You get both of those.
Okay.
So we do give them the list of bladder irritants as well, and we say, don't drive yourself crazy, but see if cutting back on these helps.
Yeah.
And most of the time, if especially if they're doing a lot of it, it does help.
Oh,
that's
all right.
number one. So again, behavioral changes.
Okay.
Emcella chair also works for urgency incontinence.
Oh, okay.
So that has a dual purpose.
Great.
And some women do have mixed urgency and stress incontinence. They have both. And so the Emcella chair is a good one.
Great.
Yes.
Good.
So bladder irritants, we do have several medications for overactive bladder and urgency incontinence.
Okay.
These medications help to relax the bladder and allow the bladder to fill so you don't feel that sudden urge. They give you
Okay.
more time to get to the bathroom.
Got it.
A lot of older drugs that we don't love to use anymore, but sometimes for insurance coverage we have to. But the newer drugs like Emcella or Myrbetriq, very minimal side effects and very effective. You just take them once a day,
Yeah.
and they help with that bladder control.
Okay.
Yes.
All right. Not a bad option.
For the postmenopausal, vaginal estrogen, believe it or not, helps with that urgency.
Wow.
Yes.
It really does help with a lot of things.
Yeah, it's a miracle. So some women, that's all they need.
my gosh.
That's all they need. You give them the vaginal estrogen, and often I'm giving vaginal estrogen and Myrbetriq or vaginal estrogen and Emcella. Once the estrogen gets going, we can stop the medication.
Wow.
Yeah. It's really pretty crazy. And you don't
Okay.
learn about this in med school. You don't learn about this in residency.
Where do you learn about it?
In practice, I guess.
Yeah.
And from ISWISH, the
Yes.
Society for Women's Sexual Health.
That's pretty great.
Yes. And
Yeah.
all these people that you're having on your show. They
Well,
all
them
talk-
too. And it sounds
they
like
all
you
talk
teach
about
each
it.
other.
Yeah. Oh,
Right?
for sure. Yeah, for
because
sure.
you learned
Yes.
from Dr. DeLucia.
Yes.
It feels like
and
it's
Dr.
all...
Rubin.
Right.
Because she always speaks at ISWISH. I've never met her
Yes.
personally, but
Yeah.
Dr. DeLucia I know very well. But yes, this is where you learn these things. And just being
Okay.
out in practice, you definitely pick up these little
Okay.
pearls.
All right.
So medications, vaginal estrogen, the Emcella chair we talked about. Then you're moving on to third line treatments.
Yeah.
Third line treatments, there's 3 really.
All right.
Botox, believe it or not. Yes, not only for our faces and our necks. You can inject Botox into the bladder muscle. I did it today, actually.
Really?
And it helps to relax that muscle. So it's similar to the medications. You don't get that aggressive contraction.
Interesting.
Yes.
Botox for your bladder.
Yes.
All right. What else?
And InterStim, which is basically a pacemaker for your bladder.
Okay.
It is a small device. It's about this big,
Yeah.
a couple credit cards in thickness, that we implant in the lower back.
Yeah.
And it has these leads that tunnel to the nerves that control your bladder, and it helps with bladder control.
What is it doing?
It's actually stimulating those nerves to help control them.
Okay, hold on, just so I have the right visual.
Yes.
What is being implanted?
So it's this small device. The small device is actually the battery, and then there's these leads that emit signals to the nerves in the lower back that control your bladder.
Interesting.
Yes, there's a couple companies that make them. One of them is Medtronic, which both my sister and brother-in-law work for, so we can talk about them.
Okay.
It's a 2-part procedure, which is kind of nice for patients to know that. You know, it sounds like a little scary and aggressive, but the nice thing about it is you can try it before you actually buy it, kind of thing. You know, you're not buying it, it's covered by insurance, but they put the device externally at first. And so you do like a trial period of 24 to 48 hours where they put the device on, you walk around, you keep track of your symptoms for 24 hours before and 24 hours after. If you have 50% improvement, then we implant the device. It's third line for a reason. You know, you try other things first, and then if nothing else is working and you're still peeing your pants, it's an option.
What does it look like?
It looks like a small silver plate and a few
silver plate.
Credit cards in thickness. It's really tiny. It sits right flat into your skin. The incision they make is like this big.
Yeah.
And you know, it's effective for a lot of people.
Very interesting.
But again, you try it. So if it doesn't work for you, you don't get the surgery. If it works, then you do it.
All right.
Yeah.
Okay.
So that's 2. And then 3 is an interesting procedure called PTNS, or posterior tibial nerve stimulation.
Okay.
And it involves a small acupuncture needle, a very tiny needle, that we put in the ankle, and it stimulates the posterior tibial nerve. This nerve exits the root fiber the same as the bladder nerve.
Yeah.
So in stimulating it, similar to the InterStim, you're stimulating this nerve, and it somehow helps with bladder control. I didn't make these things up, so I'm not the engineer or the scientist. But again, that's an in-office procedure.
Okay.
So patients often elect to do that before the InterStim, not always before the Botox, because the Botox is kind of quick and easy.
Sounds kind of easy.
Yes. The PTNS is a 12-part treatment. You have to come to the office 12 times. And I usually tell my patients, listen, try a few.
Yeah.
If you feel like you're getting better, then we'll go through the whole 12. And a lot of patients do like it.
Okay.
And then after that, if that's helpful, they do the 12, then they do like a maintenance program of once every couple months or something like that.
So when they come in, it's like they get an acupuncture needle in the ankle.
Yes.
And then they just sit there?
And then we hook up a stim machine to it. Oh. Yes, and that stimulates
and it just
the
activates.
nerve. Yes.
For like an hour?
30 minutes usually.
Okay.
Yes.
Not painful?
And no, not painful. And now someone very smart came up with something called an e-coin. And I'm not going to lie, I have not done any of these. My partner does these, where you actually put something in the ankle, like a little coin. It's implanted, so there's a little incision, and then they can do it at home. So they don't have to come to the office. So people that really like that makes sense, because they can just do it whenever they want.
How interesting.
Yeah, it's called e-coin.
So no side effects from that?
Really, no, not that I've heard of, no.
And is it basically strengthening the nerve?
It's stimulating that nerve, which I guess is changing the way that nerve is stimulating the bladder.
Wow.
Because there's something going on with those nerves that bladder is firing when we don't want it to,
Yeah.
and leading to those incontinence and urgency episodes. So this is sort of retraining that.
Oh my God.
Yeah.
It's really interesting.
Lots of stuff.
I mean, there's so many options, which I think is just great.
Mm-hmm.
It just makes, when you get some kind of diagnosis, or when you're having some kind of pain or just irritant or whatever, you just feel like you're kind of helpless.
Totally.
And so I love knowing there's so many options. By the way, what are the blue things?
Oh, the blue things. Those are
I just noticed
those
them.
are pessaries.
Okay.
So pessaries are we haven't actually gotten to this yet, but they're for prolapse, which is another problem that a lot of women face that I see a lot of women for.
Is this bladder prolapse?
This is bladder prolapse. You can have rectal prolapse. You can have uterine prolapse.
And does that mean it's
cervical
just kind of
prolapse.
like, it's just kind of like retiring?
Yes. What's happening is sometimes when those muscles are stretched during childbirth or just as we get older and our muscles atrophy, the bladder can fall down into the vagina. So women will describe a bulge in the vagina, or they feel like they're sitting on a tennis ball. For rectal prolapse, they'll feel that they can't empty their rectum completely. Sometimes they actually have to push it back in to empty. Same with bladder. They feel like they can't empty and empty their bladder completely, so they actually have to like insert a finger, push the bladder back up so that they can empty it.
Okay, so that's all prolapse.
That's prolapse, yes.
Oh, wow.
And yes, it can happen to young women, old women, sometimes after childbirth.
Yeah.
And for that, this is one of the first treatments that we try, and these are pessaries. So, we're sort of the generation after diaphragms. Not many people know what a diaphragm is, but it kind of reminds me of that just from what I've heard about diaphragms.
Yeah.
This is a rubber disc that a woman would insert, or the doctor would fit her and then insert it for her the first time, and it goes basically up to the cervix. If the patient's had a hysterectomy and there's no cervix, then you just put it up to the vaginal vault, and it suspends the vagina so that it doesn't fall down.
Oh, it's like lifting it up.
Literally lifting it up.
Oh my gosh!
So this is a pessary,
and then it just stay there.
Yeah. A good option for someone who maybe isn't sexually active, or even sexually active and doesn't mind pulling this thing out.
Because you got to take it out.
Yeah, you got to take it out during. I would think. I mean, I haven't had a patient that told me they have intercourse with it in.
Okay.
For my older patients, we see them, every couple months to change it out and wash it out and put it back in.
Yeah.
For my younger ladies, they'll take it out in the shower and they'll just rinse it off and then put it back in. I've never had one in, but so a patient comes for their pessary fitting, and my nurse practitioner often does them, but we put it in, we try different sizes, they sort of walk around, they squat, they like pretend like they're sitting on a toilet and pushing to make sure it doesn't just like pop out on you.
Right.
And most of the time you put it in and you forget it's there. It's kind of like having a tampon up there.
Yeah.
You put it in, you kind of don't know it's there. The Nuva ring is similar.
Right.
It also would help with rectal prolapse, but mostly bladder prolapse.
Okay. Mostly bladder.
Yes.
All right. Rectal prolapse is when that just kind of falls down.
Yeah, so the rectum's coming down. Sometimes chronic constipation can cause that.
Okay.
You're pushing, and eventually the posterior, the back wall of the vagina just gives out, and then you're going to have a little bulge from the back. Again, patients feel like they have incomplete emptying of the rectal vault.
Yeah.
Surgery usually repairs that. This may work. This may help.
Okay.
But usually they'll need some sort of reconstructive surgery.
All right, and you do those surgeries?
I do those, yes. Rectocele, we call them rectocele. A cystocele is the bladder.
Yeah.
And a uterine prolapse, or an enterocele too when that comes down. So we do an incision in the vagina. They used to make these big mesh kits that we would put in for prolapse. Those all got taken off the market by the FDA because they caused a lot of issues with infection, erosion, pain.
Different from the mesh though on the sling.
Exactly.
Okay, those are all good.
Those are allowed. Those are those tiny little, these were like big mesh kits that that
so the mini sling is like the size of a Band-Aid.
The size of a Band-Aid, exactly.
Okay.
Or a piece of tape, I usually say.
So different than what you do for the prolapse.
The prolapse, we are just using your own tissue. So we make an incision, we kind of push the prolapse back, and then we tighten the tissue.
Interesting.
Yeah. The unfortunate thing is it can recur. 20% recurrence rate with those surgeries, just because we're relying on your own tissues to then hold up to the pressure.
Right.
But we do have pretty good success with them.
Well, if it's 80% success, that's not bad.
Exactly. And it's usually the older women with less forgiving tissues, less strength to their tissue anymore that tend to recur.
Yeah.
Yeah. But those are tend to be the ones that are electing for the pessary anyway.
Oh, okay. Yeah. All right. Yeah, this seems pretty cool.
Yeah.
Seems very cool.
Yes.
Okay, well, I love how you make urology seem like it's really fun.
Thanks.
Because you wrote to us, which was so fun. Yeah. And I was like, oh my gosh, who is this?
Yes.
And then you, I think, connected us to your TikTok.
Yes.
Oh my God. First of all, like, you're the reason I like TikTok.
Good.
And it's just fun.
Yes.
It's really fun. You like bring us with you into the operating room. You're like telling us what you're doing. It's just amazing.
Thank you.
I really love how you do that.
Thank you.
Takes the process, which can be so scary, Like, and it just makes it like, oh, here's what we're doing.
Right. It's funny because you're saying makes it less scary. I posted a video about a prostate biopsy.
Yeah.
And every man is writing on it, like, I'm never going to have that done. If you were trying to get more patients, this was not what you should have done.
Oh.
But it has 500,000 views and thousands of comments.
Well,
so, yes.
And got engagement.
And guys should know anyway what they're getting into.
Sure. Because you don't just treat women, you treat men as well.
As well, yes. Yeah. I'm a female in a practice of 9 men.
Yeah.
And I do general urology, but I mostly do female urology because there's not that many female urologists in my area.
Right.
And some women just want to see women. And for some of these sensitive issues, it makes sense.
Yeah.
Yes.
I mean, definitely.
Yes. But TikTok has been a great outlet for me to, make my career a little bit more fun, for sure. And sex sells on TikTok. If you talk about anything sexual, anything controversial, anything with, painful intercourse or penis enlargement or,
right.
Hormones, you're going to get following. And
right.
I like talking about all that stuff and learning about all that stuff because a lot of it is self-taught. So, we have to teach each other, like you said.
Yeah, definitely.
Yeah.
Well, I love what you're doing. I really so thank you for taking the time out of your date night to come and talk about UTIs and leakage.
I hope this was helpful. I hope everyone learned something.
Oh my gosh.
And a lot of women, I'm sure, that have these issues feel unsexy about it. So I think it all sort of fits in with this sexual health and will make you feel better about yourself. And then, of course, positively impact the rest of your life.
Exactly. I just don't want people to suffer in silence and then think that there's something wrong with them.
Right.
Because turns out we all have stuff.
Right.
So typically if you have something, somebody else has it too.
Right. And 9 out of 10 women that come in tell me, why don't my friends don't talk about this? Or until someone pees their pants at dinner or nobody's saying, oh, I have that too, kind of thing. Which
exactly. Which is why I think we should talk about it openly and often.
Yes.
If somebody wants to be a patient, where do they find you?
Well, they can go to my TikTok for one.
Okay, great.
But I'm located in Morristown, New Jersey.
Okay.
I'm affiliated with Morristown Hospital Atlantic Health.
Yep.
And, you can find me on my website.
Okay, and what is your website and what is your TikTok?
TikTok is at Dr. Anika Ackerman. Website is dranikaackerman.com.
Thank you for breaking it all down, demystifying it, and just making it fun too.
Well, thank you for having me.
I'm Jacqueline Buckingham. Welcome to your most powerful chapter. Wherever you are on the pause spectrum, this is where you begin. Go to joinmeno.com and get early access. These are the answers, and we bring you the experts that have them.